Okay. Good afternoon, good morning, good evening, wherever you are. Good something. Hope everyone's doing well today. And we have one presenter, two discussants. So do you want to quickly introduce yourselves? Then we'll go ahead and get started.
Yeah, sure. I'm Sarah. I'm a medical student at Emory University here in Atlanta, Georgia. I'm applying for residency in neurology. I'm excited to present a case today.
Awesome. We love to hear it. Glad to have you presenting. Do you know my good friend and colleague, Casey Albin there? Have you gotten to work with her?
Yes, I do. And she actually told me that I should try and connect with you. And I was like, I'm pretty sure I'm going to meet him soon.
There you go. Perfect.
So,
Okay.
yeah.
Give my best to Casey. Fantastic. And who else do we have this morning?
I can go next. I'm Sebastian Green. I'm one of the neurology residents at UCLA in my final year. So, Sarah, I'll tell you the journey is worth it. I'm very excited for you to be applying into neurology and I hope we don't put you off.
Very good. What are you doing next year, Sebastian?
I'm doing a neurophysiology fellowship at UCLA. Yeah, focusing mostly on EEG, but also some intraoperative monitoring with Mark Neuro.
Very cool. All right. They're lucky to keep you around for another year. And who else do we have?
Hi, I'm Vijay, one of the CP Solvers members. I'm a pulmonary critical care fellow from India. Excited to be discussing a case today.
Excited to have you. I think
I've been a discussant when I was in my medicine residency. So
I remember
back to
you.
be discussing a wonderful case.
Yeah,
And
fantastic. Good to see you again. Okay, we're recording. Does anyone need to be co-host and put the screen up and all that stuff? Excellent. We're all set. Okay, Sarah, why don't you tell us just the chief concern and we'll go ahead and get started.
Sure. This is a 41-year-old female who presents with weakness and numbness.
Weakness and numbness. Okay, VJ, Sebastian, one of you want to tell us briefly, we don't have too much information here, but briefly your approach to weakness and the other, your approach to numbness?
I think I'll go first. So it is a 41-year-old female presenting with weakness and numbness. So I'm just thinking, where do I localize both of these symptoms? So the weakness I think of in the entire from the brain to my peripheral nerve. So whether it is in the central nervous system or the peripheral nervous system. So if it is in the central nervous system, so I think whether it is pyramidal or extrapyramidal. So weakness predominantly, I'm thinking mostly should be pyramidal more than extrapyramidal and localizing it across the entire neural axis with help of associated symptoms if I have any presence of cranial nerves or any associated symptoms. So this is what I'm thinking of. Coming to numbness, so the same thing I would think of even for the numbness uh, would be the spinothalamic tract or from the cortex again till the nerve. Uh, so this is what my approach to weakness and numbness happening together. So the other thing is so this is what I'm thinking of. So common things should be peripheral numbness predominantly usually happens more peripherally, but systematically I would approach it from top to below or below to top. So that's what I'm thinking of. And the time frame of all of this would be very crucial to get the diagnosis.
Very good. Yeah, excellent. Great. So big branch point, as you said, central nervous system versus peripheral nervous system for both of these. Yeah, Sebastian, you're going to add something?
No, I was just going to say I agree with VJ. I think as always, I think tempo is going to be critical, and really the key here is trying to localize it. And those two symptoms obviously can localize really anywhere across the neuroaxis from the brain, maybe even to the muscle. I mean, some of the mitochondrial myopathies, also affect the brain, and therein could cause some numbness. So really um, transecting the entire neuroaxis. I think the two of them coming together does make me think of a peripheral neuropathy above everything else, just because having a lesion of the central nervous system causing both weakness and numbness, and we don't know the distribution, but that might be more devastating, and there might be significantly more to the history exam than somebody being able to walk in and self-present. But those are my initial thoughts, but obviously it's a very open-ended chief complaint. So
Yeah, totally agree. Yeah, great thoughts from both of you. Yeah, we don't know yet, as Sebastian said, the distribution is this bilateral, proximal, distal mix of both. He said if she could walk in, we don't know if she can walk in. We don't know if there's um, uh, changes in mental status as well. But yeah, just to start getting the lay of the land, if you heard this or you got this page and you were just starting to draw the map in your mind of what you're thinking about, um, weakness could be anywhere on the along the neuroaxis: brain, brainstem, spinal cord, nerve roots, nerves, neuromuscular junction, or muscle. And numbness can be any of those places as well, except neuromuscular junction and muscle. So off the bat, if we know that there's weakness and numbness, as Sebastian said, that does help us and make us think a little bit more of some things than others, though the distribution, without the distribution, it's quite hard to say. Um, so we can at least take neuromuscular junction and muscle off unless the patient has two problems, right? A neuromuscular junction or muscle problem and something in the brain, brainstem, spinal cord, nerve roots, or nerves. Um, Weakness and numbness together, if we were in the brain, right, we'd have to have both motor and sensory pathways. That's certainly possible. Probably if we have something getting two gyri, maybe we would get some more. But if this is unilateral on one side, involves the face, we'll be thinking more of something in the brain. Weakness and numbness together, very common in the spinal cord. For in the spinal cord, um, you can get a unilateral spinal cord lesion. The spinal cord is pretty small, about the size of one of your fingers, so it's hard to just get one side of it, but you could get a Brown-Séquard syndrome, and then there would be weakness and numbness on one side, and then the sensory exam would be dissociated. And probably, though not always, we could have bowel and bladder, but if it's a small enough lesion, as can be seen in certain conditions like MS, you might not get bowel and bladder. And then peripheral nerves, Sebastian said just off the bat, we think weakness and numbness together. If this is symmetrical, then we would be thinking uh, more on the peripheral nerves or spinal cord, and then bowel bladder may or not, may not help us there. And then, yeah, so you both want to know the distribution and the time course. Those are going to be key. Off the bat, if you said this is a 41-year-old with new weakness and numbness, just age, sex, symptoms. We don't know the time course yet. Anything just kind of jump to mind, even though we have very little to work with. Sebastian or BJ?
yeah, I think multiple sclerosis is something that would come to mind first, but
Yeah,
you
yeah,
know,
for me too. Yeah,
I
yeah,
think
hard not to.
I
Oh,
think
sorry.
the first case I brought to CPS was a woman about the same age who had a very different diagnosis of porphyria. So who knows?
That's
If
fair.
MS comes to mind.
MS comes to mind. I agree as well. Yeah, if this is weakness and numbness, that is unilateral or bilateral, maybe bowel bladder, maybe not. MS tends to cause pretty small lesions in the spinal cord compared to other immune-mediated myopathies like NMO and MOG, which tend to cause true transverse myelitis affecting the whole cross-sectional area of the cord. This age, that tempo, that might be what we would be thinking of. On the other hand, if we hear this as ascending weakness and numbness, maybe we'd be thinking more about something like Guillain-Barré. But as Sebastian put it well, the field is wide open here. So, but the main things VJ, Sebastian, and I are all sort of now tuned in for are the tempo of progression of symptoms and then the distribution: unilateral, bilateral, proximal, distal. These are all the things that are going to help us localize this, and then any associated symptoms, a preceding infection that make you think more of Guillain-Barré, depending again on what the distribution and tempo is. Preceding history of optic neuritis or something like that would make us think more of something in the MS, NMO family. But those are some initial thoughts just with the couple of words Sarah gave us so far. So, okay, Sarah, if you don't mind rounding out the rest of the history for us so we can dig a little deeper.
Sure. So Miss X is a 41-year-old female who presents with 3 months of progressive difficulty walking and numbness, which began in her feet. Her outside neurologist prescribed pregabalin, which was titrated to therapeutic dosing without significant improvement. The onset was insidious and progressive. Other symptoms include numbness and pins and needles in her hands and feet, which have worsened and kept her from sleeping despite topical treatment with diclofenac. She states that her outside neurologist had performed extensive tests and imaging, including MRI, without a cause identified. She has been following outpatient cardiology as well for episodes of tachycardia and hypotension and received a diagnosis of POTS. She continues to have intermittent episodes despite treatment with Nadolol. Her outside cardiologist also started to work for mast cell activation syndrome, for which she takes cetirizine. She's not had any recent GI or viral illnesses and received an incomplete vaccination series for COVID-19 due to significant side effects. She has no new urinary frequency, travel, rashes, and her ROS was otherwise unremarkable. I can either move on to like past medical history and exposure history, or we can take a pause there.
Yeah, you can round out that column if you don't mind. Yeah.
Yeah, sure. So she has no known drug allergies, no surgeries, family history, including maternal grandfather who had a heart attack at age 50, no family history of autoimmune conditions or cancers. In her exposure history, she lives on a farm, cares for chickens and pigs, has 3 dogs that sleep in the bed with her, no illicit drug use, but vapes 1 to 3 times per week, and occasional use of Delta 8 marijuana. She's monogamous, and her house was built in the 50s.
Okay, lots of interesting things here. You said, Sarah, no urinary frequency. Is it fair to say no bowel or bladder symptoms at all here, or just no urinary frequency?
No bowel or bladder symptoms as well.
Okay. All right, Sebastian, VJ, what do you make of all this?
I can make a comment. So, the fact that it's just thinking first about localization before we dive into kind of differential, the fact that it's symmetric and kind of affecting both lower extremities. We talked about distribution and modalities, both numbness and weakness. The fact that we have positive as sensory symptoms all really points towards the peripheral nervous system, and specifically, I think at this point, the peripheral nerves. Also, maybe some autonomic nervous system involvement, given this sort of postural, tachycardia that was described. Um, so that's where my head is at, and the time course throws in a few specific differentials. I'm going to throw infectious out there, given this history of working on a farm and showing bedded animals, but also of course lots of non-infectious etiologies, right from kind of chronic inflammatory etiologies like CIDP variants. Um, and then metabolic and nutritional, obviously kind of invoking B12 deficiencies, but also copper and zinc, and then and then I suppose other inflammatory etiologies, sort of autoimmune conditions. Again, you asked about what comes to mind when I think of females in this sort of age category, and autoimmune disease comes into mind as a potential cause of a peripheral neuropathy. So that's where my head is at right now. I have just thinking anecdotally about the patients having severe sort of COVID-19 side effects. I've had patients in my clinic with small fiber neuropathies post-COVID vaccination, and I actually did nerve biopsies on some of them. I do have inflammation of the nerve fibers, and so I wonder if she's again somebody who is quite an inflammatory individual and maybe kind of raises my index for an autoimmune process slightly higher. So that's where my head is at right now. I'd love to hear, VJ, if you have any other thoughts about what you think is going on, and maybe if there's anything else you'd want to know from the history.
Just quickly, yeah, before we turn to VJ, Sebastian, you that was fantastic. Thinking about a lot of the same things that I'm. You mentioned CIDP, just for folks who might not
Yep.
know what that is. Do you want to just briefly
Yeah,
discuss?
so CIDP stands for chronic inflammatory demyelinating polyneuropathy. It is the chronic form of acute inflammatory demyelinating polyneuropathy, which is better known as Guillain-Barré syndrome and its variants. So CIDP is essentially GBS lasting, I think it's longer than 6 weeks. But you might have to, I think it's either 4 or 6 weeks, get confused, but at least 8, is my understanding. But usually a chronic form of Guillain-Barré syndrome associated with, and there are several subtypes of CIDP that we can test for, but that's again something that comes to mind. Often treated with immunosuppression. I have patients who might get IVIG every 2 weeks for it if it's really severe, and others who are just on other forms of immunosuppression.
Yeah, excellent. And would autonomic dysfunction be part of CIDP
Yeah,
typically?
it definitely can. Yeah, and I mean, in GBS, I think you're turning your head saying no. I think GBS can certainly come with like autonomic issues. So I'm assuming by extension CIDP does, but maybe you're going to correct me.
Um, I could be wrong about this, so definitely fact check me. You're right. Guillain-Barré, there can be significant autonomic dysfunction, heart rate irregularities. Um, I even heard about a few cases of GBS where the blood pressure was swinging so wildly the patients got press, and that's described in the literature. Um, CIDP, as you said, I think of it as like the chronic cousin of Guillain-Barré. It's a demyelinating polyradiculoneuropathy, but I forget if it's the onset is supposed to be longer than 8 weeks, or I don't remember the exact number, but as you said, Sebastian, it's a more subacute rather than acute. GBS usually nadirs in about 2 to 4 weeks. And there's a for CIDP, like Guillain-Barré, there's a lot of variants, but CIDP, there's a pure sensory, a pure motor. Um, there's a more focal presentation. I don't remember all of them. There are um, several variants. But CIDP is sort of a description of a syndrome. It doesn't have a specific biomarker. To my knowledge, though, it doesn't typically affect the autonomic nervous system. Maybe there are case reports, but I say that it's a syndrome um, because it's diagnosed by criteria, not a biomarker, in the sense that there's a characteristic clinical syndrome, and then there are neurophysiology criteria on EMG nerve conduction to prove demyelination related to conduction block, um, distal latencies, um, slowed velocities, etc. However, recently it's been described that there are these antibodies that they're patients that look like they have CIDP or some version of it that don't respond to typical treatment with IVIG, and were found to have a couple of different syndromes called, they're now classified as nodal or paranodal antibody-related syndromes with antibodies to neurofascin, to contactin, I think are the main ones. Someone presented one of these ones here, and I've seen one in real life. I don't know about autonomic dysfunction in those, but they tend to be more um, severe than GBS, and each of them has a sort of particular phenotype. Um, yeah, so I was thinking in the CIDP family until I heard that autonomic dysfunction. That doesn't sound too CIDP-ish to me, but in that we're sort of in the family of, I agree, it certainly sounds like a neuropathy. There's progressive weakness and numbness that began distally. There's positive symptoms, as you said, the pins and needles. Also does sort of sound root and or nervy. Um, and so we're in the kind of subacute sensory motor autonomic neuropathy field, and CIDP without the dysautonomia I think would be there, but it's just important to remember there's other things in that differential which we'll talk about, and Sebastian mentioned some of them. But let me hand the microphone to you, Vijay. Sorry, I just wanted to talk a little bit about CIDP and associated disorders. And yeah, if anyone has fact checked, I haven't looked at the chat, let me know if you can see dysautonomia and CIDP, or that would be kind of a case reportable thing, but I don't think it's typical. Um, Go ahead,
I
Vijay.
have, I have nothing to add. So one thing that so I think CIDP is not typically not associated with autonomic dysfunction. So that is what I remember reading. The other thing is how I make progress of this is must be something secondary. Routinely, when we think of neuropathies, polyneuropathy, so it is usually sensory symmetric and usually subacute in nature. So what we are seeing here is a combination of a component of an autonomic dysfunction as well here. Probably some component of episodic tachycardia. So we're not very sure we have the diagnosis of POTS here. So what I'm thinking is there should be some other secondary cause rather than uh, the routine causes that we think of like metabolic causes. So the other thing I'm thinking is there a component of so if I'm thinking of fibers, maybe it is both small and large fiber because we have both positive and negative symptoms. Um, when have autonomic involvement, so one thing I'm considering is a component of toxic or metabolic causes. The other thing is like an amyloid. So amyloidosis is one for a classical autonomic involvement. Uh, the other thing is, like Sebastian said, vaccine related, COVID vaccine related is so any underlying autoimmunity can be unmasked. So other thing is, I would be interested to know if we have any other systemic signature apart from the neuropathy, because I'm thinking of all secondary causes that could be there. So at this age group, one would be a connective tissue like an extragranular Sjogren's, if I have some clues to it, because it could very well affect all of the systems. And the age also fits for a young and autoimmunity at this age group. So these are my thoughts as well.
Yeah, fantastic. Yeah, so we're in the field of neuropathy. It sounds like we'll confirm on the exam that the reflexes are gone. Be nice to know, although it's hard to say based on the history, we'll find more on the exam if we think this is demyelinating or axonal, which we'll talk more about as we get the exam. But it seems to be a neuropathy. Hopefully, we're on the right track. And it seems subacute, and it's affecting motor, sensory, and autonomic. So subacute neuropathies, we talked about CIDP. We talked about some of the what I call the carve-outs of CIDP, things that used to be sort of atypical CIDP, now are called nodal or paranodal antibodies. I don't know if any of those specifically do dysautonomia. And then, as you mentioned, if we're working up a subacute neuropathy, since CIDP, for example, has diagnostic criteria, but again, they're not specific. You could have a demyelinating neuropathy that it's not CIDP, that like any criteria that where there's not a specific biomarker says and other causes are eliminated. What other causes? You both mentioned systemic conditions. And in this age group, again, autoimmune conditions. So you can see a CIDP-like syndrome in lupus. You can see a CIDP-like syndrome in Sjogren's, small fiber neuropathy in Sjogren's, autonomic neuropathy in Sjogren's, sensory ganglionopathy in Sjogren's. We still don't know if the weakness is true neuromuscular weakness or the patient has so much numbness that they're uncoordinated, clumsy, etc. This is a pure sensory neuropathy. Should be wanting to look for lupus, Sjogren's. I think you can get a neuropathy in sarcoid, probably. You can kind of get anything, but not one of the more common, to my knowledge anyway, manifestations of sarcoid. And then, good, you mentioned amyloid. If you see neuropathy and heart, think of amyloidosis. I think it's usually heart failure, not sort of heart rate variability. Um, but heart plus neuropathy, that's in the schema. Um, Heart plus nerve plus dorsal columns. I guess you could think of Friedreich's ataxia, but that's an X-linked condition. So we shouldn't be seeing that in a female patient. So what else? We're getting the sense that it's symmetric, so a vasculitic neuropathy, probably less likely. Those usually asymmetric mononeuropathy, multiplex, and I wouldn't think of dysautonomia with that. And then, as you mentioned, we're still really learning about how to make sense of COVID-related complications, et cetera. And I think we're still making sense of what um, what that is, what post-COVID syndrome is. And some patients do have POTS and other syndrome complexes like this. But that would sort of be a diagnosis of exclusion since we wouldn't be able to prove it. So on our exam, we're want to get a sense first to make sure the reflexes are down or out, because we've been talking about neuropathy, but sometimes you get to the exam and you say, ooh, the reflexes are not what I expected, back to the drawing board. And then probably we're going to want to send a lot of labs. And we mentioned what many of those would be. What else? Oh, people mentioned, you mentioned, sorry, B12 deficiency. Dysautonomia, I think, would be pretty atypical for that as well. But yeah, in this subacute time courses, there's some toxic exposure. Sarah gave us a very detailed, provocative kind of infectious disease consult here of all the animals and that the house is old. What toxic things here? So heavy metal poisoning can cause a neuropathy. Um, Sometimes my overeager residents send a heavy metal panel, and then it's not uncommon for stuff to come back abnormal on there. It turns out if you eat a lot of seafood, for example, a lot of, I think both arsenic and mercury could be quite high. If you see a really high arsenic, then people start to wonder if somebody's getting poisoned. And but I looked this up. We had a patient who had a heavy metal testing, in my opinion, probably didn't need it and had a very high arsenic. And I found in some old textbook, like just tell them to stop eating fish for a few weeks and recheck, and it went away. So that was not the cause of the patient's neuropathy. But just to zoom out, there is a first pass neuropathy workup. This neuropathy is not behaving normally. Probably worth saying. How much time do we have? Yeah, worth saying. I have some red flags of neuropathy. Sebastian can tell you, and Sarah in a few years will be able to tell you. We see a lot of peripheral neuropathy in clinic because, well, probably 20 to 30% of them in older people are idiopathic, but then diabetes, B12 deficiency, common conditions, people getting chemotherapies that cause. So we see a lot of peripheral neuropathy. And most of the time, you really don't need a very extensive workup to either make a diagnosis or say it's probably idiopathic, unless you see red flags. And there's a lot of red flags here. But first, Sebastian, so I'm curious what you do and what is taught at UCLA, because I've seen different practices in different places, although there are AAN guidelines for what the workup is of a garden variety distal symmetric sensory neuropathy. What tests do you send or should one send? Or have you been told to send? What do
Yeah,
you be
I've
sending?
I've definitely been slapped on the wrist before for just reflexively sending everything that can cause peripheral neuropathy, and so we do have some guidelines institutionally on what we should be sending, and at a minimum, usually we will send an A1C, a B12, and a folate, and we actually send that with homocysteine and methylmalonic acid on everybody institutionally. I don't know the utility of that. I can see again you're shaking your head, so. Uh, B6 is quite popular. We often send B6, again, more shaking of the head. I mean, anyone over 60, 65 will definitely do protein electrophoresis studies. And I'd say that's and a TSH. And again, I've been told that thyroid neuropathy is well very rare and low yield, and but that would be our typical first pass screen, and then you can add additional labs depending on the clinical features. And I say the kind of the next most common set of labs that we'd be sending would be an ANA, and I know that's been you're really asking for trouble sending that. We often send a SED rate, an RPR, and an HIV would probably be on a kind of second pass screen, but I think that's where I'd start in the garden variety neuropathy.
Got it. So, yeah, I've seen all sorts of diverse practices in this space. Fortunately, our American Academy of Neurology did the heavy lifting for us and went through the literature and decided what is actually high yield, low yield, no yield. And the guidelines, which I think are, I don't remember when they're from, but the first author is England. They were recertified because nothing really changed in the literature a couple years ago. So you can find the AN distal symmetric sensory neuropathy guidelines, which tell you the first pass workup is only 3 tests. Some tests for diabetes, vitamin B12, and SPEP with immunofixation. Stop. Those are the tests because diabetes is common. B12 deficiency in some populations surprisingly common. We think patients would have to be vegetarian or vegan or using nitrous or have a gastric bypass. But I think both metformin and PPIs can inhibit absorption of B12, so it's not uncommon. Then the SPEP, I think maybe once in over a decade have I picked up paraproteinemia of significance in a patient with an otherwise unremarkable neuropathy. Usually it's patients with myeloma who come because they've developed neuropathy and you don't need to obviously send a SPEP. All the other tests Sebastian listed could be part of a second pass, but are not recommended by the AN in the first pass, including what many people get a TSH. As you said, please don't get the ANA. It's going to be 1 to 40, 1 to 80, and then you're off to the races. And for some reason, a lot of people send an RPR in the neuropathy workup. Correct me if I'm wrong. I do not believe that syphilis can cause a peripheral neuropathy. And I don't know if this is kind of bleeding over from the reversible dementia workup, which has a lot of the same things, or if people are saying, well, what if I'm faked out and it's actually tabes dorsalis? But I work in a region that has a fair amount of syphilis. I asked our syphilis expert or neuroinfectious disease person, have you ever seen tabes? And she said, no. I think it's very, very rare in the modern era. So first pass, B12, A1C or glucose tolerance test, and SPEP with immunofixation. And then if it's an older person and if it's a neuropathy, that's right, Sarah, I'm sending HIV, I might as well send it the RPR, the slippery slope of diagnostic testing. Yeah, if it's a neuropathy, if I say that neuropathy is not behaving badly, and what do I mean by behaving badly? Most neuropathies you see in practice, Sebastian, I bet will tell us 999 or so out of 1,000, maybe 990 out of 1,000 are distal, symmetric, sensory, and chronic. What would you say, Sebastian, out of 1,000? 995?
Yeah.
Yeah, okay. Distal, meaning axonal, symmetric, sensory, and chronic. If any of those four are violated, then you send whatever you want. Fill your shopping cart with lab tests. I'm not going to ask too many questions. So how would these be violated? What do I say when a neuropathy is behaving badly? Acute to subacute time course? Check. We have a subacute time course here. Any motor or autonomic involvement? Of course, you can get those with diabetes, but they would be rare for diabetes or rare unless the diabetes is very severe or long-standing. And before you blame it on diabetes, you'd want to work it up further. Asymmetric, some neuropathies you check in a patient with diabetic neuropathy and kind of looks like one sock higher than the other sock kind of distributed. That's okay. But markedly asymmetric, one foot, not the other foot, one hand, not the other hand. That makes you think more of mononeuropathy. Multiplex, again, rare, you're off to the races. And then, was that all of them? Yeah. And then, oh, not distal. So if it's non-length dependent. So I should have said length dependent versus non-length dependent. We'll maybe get into that in a little bit. But many non-length dependent demyelinating neuropathies are still distal predominant. The feet and hands are more affected, but the proximal regions are affected at onset as well. So those are the red flags for neuropathy. If you see anything other than distal, symmetric, sensory, chronic, then I will not shake my head for any lab you tell me. And what is the second pass workup? Yeah, it's looking for autoimmunity. It is looking maybe for more exotic toxins, like heavy metal testing. This house built in the 50s, what could be in there? Lead paint, maybe. Lead, yeah, I haven't seen too many lead neuropathies, but maybe that's what Sarah's giving us many red herrings or trying to clue us into. I don't know of anything from dogs, chickens, pigs related to the peripheral nerves. Maybe some fertilizer of some type of toxicity or something like that is all I can do with that. Didn't mention cows. I don't know, what's the, oh, it's on the tip of my tongue, brucella. I think it can cause a myelopathy. I don't think it can cause a neuropathy. Anyway, I've never heard of anyone getting a case of brucella. Okay, so we've talked a lot about neuropathy. Maybe Sarah has led us down the garden path. She's going to say, I didn't tell you. And then the patient lost all bowel and bladder control and became quadriplegic. And then we will have had a nice session talking about neuropathy and still have about a half hour left to talk about whatever this is. Okay, so there's times when we go into the exam really to confirm a hypothesis, and I think that is hopefully what will happen here. But I have to say, sometimes you go and you get a big surprise, and that helps you reframe the whole case. So let's see which camp we're in here. All right, Sarah, what happened next?
I love this discussion. So I'll go on with her physical exam. Her vitals were only pertinent for slight hypertension at 143/98. Physical exam, overall normal. Pertinent positives include poor dentition, some dry scale on her anterior shins, and then scattered bruising from what she describes as falls due to lack of coordination. And then extremities, some lower extremity atrophy, but otherwise within normal limits. Her neuro exam, she had normal cranial nerves and mental status. Some pertinent negatives here. She had no ptosis and no tongue deviation or fasciculations. Motor exam, low muscle mass throughout, but normal tone. 5 out of 5 strength in bilateral upper extremities, and 4 out of 5 strength in hip flexion and extension bilaterally. 5 out of 5 ankle plantar flexion and dorsiflexion, with normal fine finger movements and no drift. Reflexes were 2+ in the upper extremities, 1+ in bilateral patellars, and absent ankle jerk with Babinski mute. Sensory was grossly intact to touch in all extremities, but did have reduced pinpoint in bilateral lower extremities and bilateral hands to the distal forearms. She said that she was able to subjectively feel, but said that it was numb. Coordination, she had no dysmetria, no ataxia on finger to nose or heel to shin bilaterally.
I'm sorry, Sarah, you said reduced pinprick in the bilateral lower extremities. How high up did that go?
I think it was up to just below the knee.
Below the knee. And then was vibration tested?
Um, I believe it was, I can't remember. I can't remember what it was,
That's
but
okay.
yeah.
Okay. All right. I have some thoughts, but let's hear from Vijay and Sebastian.
Uh, Very interesting findings that I'm seeing on the exam. So one is the dry scaling. So is there a component of is it just the part of dysautonomia, or is it something else? That is one thing that I would think of. Uh, then there is lower extremity atrophy. Uh, so I'm thinking, is it uh, so this is saying there is some component of significant. I'm not sure how to make of this with the neuro exam. So one thing in the neuro exam is there is overall low muscle mass. So is there a component of a systemic involvement that is there? Because this low muscle mass. So I would just be curious to know if this low muscle mass was low in all the four extremities, or is it there in just the lower limb or in the upper limb? That is one thing. The other thing is the motor exam. So it seems more of a proximal more than a distal in the motor, where we have hip flexion is impaired compared hip flexion and extension is impaired compared to uh, where ankle, plantar, and dorsiflexion. So the other thing is okay, fairly low muscle mass. So I think it is something systemic. So this low muscle mass makes me think in a period of 3 months with no significance. So the muscle motor involvement doesn't say there is significant muscle weakness here, very mild weakness. And I'm curious why the patient had falls. So there are three red flags that I'm seeing. So one is motor that is proximal more than distal, and as the hypothesis that we had was of neuropathy, wherein low reflexes. So that is present. So this somehow the pattern of proximal muscle with the distal sensory. So I'm thinking, is there a component of demyelination as well? Because the myelin is more uh, the proximal fibers are more myelinated compared to distal. So that is one thing that I'm thinking of. The other thing is to explain the falls. I'm not very sure how to explain the falls. So is that a component of autonomic dysfunction itself that the patient had falls, or was it something else? So is there something higher in the cortical function, but we are not seeing anything in the higher mental functions here. Uh, so what I'm thinking is there's some component of probable demyelination uh, and which is subacute with a component of autonomic. Um, yeah, I'm not really sure where to go from here.
Yeah, great synthesis. Thinking along many of the same lines. Sebastian, what are you thinking? And then,
Sure, yeah. So I think just in terms of localizing, I think the absence of reflexes, especially in the lower extremities, and that pattern of weakness does fit some sort of peripheral nervous system injury. I agree. So I think I'm wondering if there's something that's non-length dependent. That description of loss of pinprick in the hands as well as the feet. I wasn't quite sure how it's up to below the knee, distal forearm. So yeah, kind of getting a flavor maybe of something non-length dependent. The way that the hips are very weak makes me wonder if like the nerve roots are somehow involved in this and inflamed. So that's sort of and then that's in terms of localization. In terms of etiology, seeing the poor dentition, the bruising, the dry skin, nutrition and infectious, but nutritional deficiency really kind of jump out. The poor dentition, she vitamin C deficient, getting gingivitis. The dry skin is that a niacin deficiency. The bruising is that vitamin K deficiency. I'm thinking, is this someone who's really just globally nutritionally deficient? Not to mention, obviously, the atrophy and the fact that she's thin looking. So nutrition has jumped up there. I'm just going to throw it out there, knowing that the most common cause of neuropathy in the world is leprosy and that she has a skin rash. I'm just throwing it out there. But so that's where my mind is going based on the exam, and I think, yeah, that's where I'm at.
yeah, excellent. Yeah, we had what I call morning report bias, where we got into exotic, CIDP, not that exotic, but not that common, and CIDP variants and amyloid. And yeah, both of you mentioned toxic metabolic, but yeah, nutritional, B12 being the most common. And I don't know, people who practice in other parts of the country, we see a fair amount of nitrous use here, whippets, where people get a functional B12 deficiency related to that. Usually it's subacute combined degeneration, so it's cord rather than nerve in my experience. But B12 can cause cord, nerve, or both. Um, but yeah, we certainly get the flavor here outside the neurologic exam of something nutritional. As you said, the patient is emaciated, bruised, poor dentition at 41, dry scaling um, skin. Um, and then, yeah, I, like both of you, was sort of struggling for lint dependent versus non-lint dependent here. If it's up to the knee, that if you line your arm up with your leg, your fingertips go to about the mid calf. So if you're up to the knee, you probably could get hand, but you probably shouldn't get to forearm. But she's got her reflexes in the upper extremities. And usually when you have a non-lint dependent process, one of the striking things is that the reflexes are kind of out everywhere, even beyond places that are symptomatic. And, the sensory exam, any neurologist will tell you is sort of the most challenging exam to kind of perform and interpret. There's a lot of subjectivity to that part of the exam. And so, once you feel numb in your hand and the patient says, I call it the do it again sign, like, we'll do it again, compare the do it again. Once you get a do it again sign, as I say, then, you're not really sure what to make of the sensory exam. And then we have that proximal weakness, which you shouldn't really have in a length-dependent process, but she sounds, pretty overall just weak, not necessarily neuromuscular weak. So it's some of that kind of deconditioning, myopathy, maybe not getting around as much. Or is there a muscle component here as well? Because she has her knee reflexes, so probably it's not nerve or root up there. And the sort of L2 through 4 myotome. I'm going to say this is probably still length dependent. I'm also biased because I think this is a nutritional neuropathy, and those are usually axonal. What nutrient? Probably, as Sebastian said, there's multiple nutrients that are um, down here. But as far as nutritional deficiencies that could cause motor, I should say, sorry, so it could cause neuropathy and heart. Any come to mind? There's one coming to mind for me, although I'm not sure it's the correct one, but
Selenium or copper?
say again.
Selenium and copper comes into it.
To
Sure.
be honest, don't know anything about selenium deficiency, so I don't know if it just doesn't really affect the nervous system or I need to learn from you, VJ. Copper deficiency usually mimics B12 deficiency, it's subacute combined degeneration or neuropathy or both. I don't think of dysautonomia with that, although I'm sure this patient's going to have multiple deficiencies. It's pretty hard to get copper deficiency. You need to have hyperzincemia, and that used to be caused every once in a while in a CPC type of case by excessive use of denture creams. Someone can look this up and correct me if I'm wrong. I'm pretty sure the denture creams had to remove the zinc component because this kept happening. There's a very beautiful CPC by one of my mentors who you heard me say probably every time because I think of him all the time, Marty Samuels, from a couple years ago in Annals of Neurology. It's a woman of about this age. Um, it's probably the most elegant, eloquent discussion of length dependence. So look it up. It's like a 41-year-old with numbness and tingling is the title or something. Email me if you can't find it, but it's Martin Samuels. And I remember seeing the CPC live when I don't know if I was an attending or a resident. Anyway, it was when I was still in Boston. So it was sometime between 2012 and 2019. But I think 2016, 2017-ish, Annals of Neurology, Martin Samuels, a 40-something-year-old woman. That's the one. Beautiful discussion with a lot of pearls in there. So I think I'm going to call this length dependent with deconditioning, and it's sort of the reflexes that I'm using there. Although I'm not sure, just for the same reasons you are also not sure. Um, so yeah, and then when I heard all that systemic stuff, someone told me when I was a med student that this kind of off the charts rheumatologist who was like the most masterful master clinician at Johns Hopkins at that time, or one of them, Anthony Rosen, when I was a med student, was just sort of always consulted in the hardest cases. There was legend that he had diagnosed a patient in the ICU with scurvy. So I don't know if that causes a neuropathy, and I didn't know you could get that without sailing across the Atlantic 400 years ago. Um, but apparently, um, you can. So I think this is going to be multiple nutritional deficiencies. What would I blame it on? Um, I would probably, oh, sorry, Sebastian, you were going to say, guess what I'm thinking? Or
Are you thinking about berry or like dry, wet berry? Yeah.
Yeah, tell me more about that. That's exactly what I'm thinking.
Okay. So these are clinical syndromes associated with vitamin B1 or niacin deficiency, and they're associated with a triad of well, there's a couple. There's I think dry, and someone will have to correct me. This dry is where you get, is it dermatitis, diarrhea, dementia, the three Ds,
I think
and
the three Ds are
it
B3
gives something
niacin
else.
is my step one recollection.
Okay.
Dementia,
Mm,
diarrhea, and
maybe I'm getting
erythema. I think
confused.
that's niacin. Um, so we don't have the dementia, diarrhea.
B1 thiamine, sorry.
Yeah,
Then yeah, all I remember is that you get heart failure and you can get neuropathy and
yeah,
very,
that's all I remember too. Yeah, dry
yeah.
beriberi causes what can look like a Guillain-Barré like neuropathy. We unfortunately in San Francisco see not uncommonly Wernicke encephalopathy, and I've seen a few patients when they wake up from it with a very severe neuropathy. I've never seen it with the heart failure, the wet beriberi, but uh, then there's this entity I've heard people describe. You can find some patients, I think called ANAN. It's not really a term in use where I trained, but when I was visiting at WashU in St. Louis, one of the top neuromuscular places in the US. The residents were telling about this diagnosis that I had not heard about and had to look up, like acute nutritional axonal neuropathy. And I had trouble reading the papers, understanding how if it's a name for an entity of which thiamine deficiency is one cause of it, or it's kind of its own thing. And I think it's like combined B6, B12. But anyway, someone can look up this diagnosis, ANAN. I'm not sure who described it. I had not heard that, and then I had trouble, like I said, reading the papers and understanding whether it was a specific syndrome or just kind of a different name for nutritional deficiency associated neuropathy. Acute um, nutritional axonal neuropathy, I think is what ANAN stands for. Anyway, don't quote me on that. Something I had looked into and then wasn't sure what to make of. Is this a term they use at UCLA, Sebastian? ANAN? I hadn't heard it before.
I, I've not heard that phrase before. No, I mean,
Yeah, I
obviously,
was trying to get a sense of how is this different than dry beriberi and was not totally
mm.
sure. Okay. Yeah, I think, as Sebastian said, we're going to see a lot of nutritional deficiencies. Why is this patient so nutritionally deficient? Sounds like they have no shortage of things to eat on a farm, but um, maybe not. And then some toxin drug doing this, such that the patient is malabsorbing and is actually trying to get their nutrition and or has a tapeworm or something, and just I don't know. I think nutritional deficiency, whether that's the primary or whether there's something even a diagnosis beneath the diagnosis, I'm not sure we could tease that apart. Okay, so for me, it would be labs. And then the thiamine lab, it's worth knowing if you think this patient's thiamine deficient, give them thiamine. The thiamine lab takes a long time to come back, and people can correct me. My understanding, what is said and what I've seen written, is that um, serum thiamine levels don't reflect brain thiamine levels. So if you're diagnosing Wernicke's, it's actually not even that useful of a test. I actually don't know how well it reflects what the nerve is seeing. Probably we'd send it out of intellectual curiosity here, but um, we would start probably thiamine B12 as a first pass. Would I send heavy metals? I mean, if I were stepwise, I'd look for autoimmune disease. As someone said in the chat, this patient could be malnourished and have an immune-mediated condition. Um, uh, and I would send nutritional labs. I would start nutritional supplementation and then kind of wait for that stuff to come back before I send heavy metals. I've just seen too many false positives there. Although this patient's drinking well water, or who knows what that house built in the 50s is still swinging in the breeze there with Sarah just trying to um, send us off in all kinds of fun directions here, or is there something going on there? And then I don't think from marijuana vaping we should see anything, although if like I said, with nitrous, you can get functional B12 deficiency. Okay, and then some people would ask, should we do a nerve conduction study in this case? Um, I would be curious to know if it's truly axonal or demyelinating. I'm not sure how much that would change. If this workup is unremarkable and we really don't have an answer, probably reasonable to do to just confirm, okay, we're in the axonal field. That is not CIDP, that's a demyelinating neuropathy. And we should be hunting further for nutritional causes. I do remember one case presented here by one of our UCSF residents, superstar Ori Lieberman. This was when I'd first got into UCSF by 2022, 2023, of a woman who we thought had thiamine deficiency based on the discussion here. He presented the case here. And he's one of our neuro ICU fellows now. And it was one of these double diagnoses that the patient had CIDP, became so weak that they were bedbound and stopped eating because they couldn't get out of bed, and then developed thiamine deficiency on top of there. It was one of these exams where it's like, I don't know, it kind of looks okay. So maybe there's a couple things going on, but my money's on nutritional. Um, it sounds like Vijay and Sebastian as well. Okay, Sarah. Hope there's not too many more twists and turns for the last 6 minutes. Are we getting close?
We're getting close.
Okay. What
So
happened?
our basic labs, CBC was normal, but her MCV was 103. Her CMP was notable for AST of 79 and ALT of 42. Folate was 2.5, which is low, and magnesium of 1.4, which was low. We sent a battery of nutritional and exposure testing. B6, B12, B1, vitamin D were all normal. Lead and heavy metal testing was normal, and her HbA1c was 4.9. Her urine drug screen was negative, and her alcohol level on admission was 0. I can give the rest of the labs, or we can kind of chat about these ones.
Any thoughts, Sebastian or Vijay?
I am surprised. I'm surprised that B6, B12, vitamin D. We've got some water and fat soluble vitamins, and they're all normal. So maybe the MCV is a little bit high, but not really high, and the hemoglobin count's normal. I'm not seeing a very convincing nutritional picture with these labs. Maybe I'm sort of pivoting more towards infectious etiologies at this stage, but it's very hard to explain all the exam findings with one infection like it was to explain all the exam findings with nutrition deficiency.
Yeah, I have another thought, but yeah, Vijay, your take here.
Yeah. So one thing is, I'm finding it hard to explain the MCV. So what I would be curious is there occult B12 deficiency? Because we don't have, we could have an occult B12 deficiency here. B12 can falsely be normal. Uh, and we have a low folate. So what we are seeing here is a low folate and low magnesium with everything others being normal. So retrospectively, I think, so why is folate low with just B12 being normal? So probably the B12 is also low. That is one hypothesis, or I'm thinking. So why should a person with uh, fairly no significant um, vegan history or anything have this degree of low folate and nutritional deficiency? So the other thing I'm thinking is their component of malabsorption. So I'd just be curious to know if we have other thing is the infectious bucket. So by default, I think one thing I would there's a reversible cause is like an uh, HIV that I would definitely want to rule out. But usually I expect it with a more autonomic dysfunction as well as more sensory more than this degree of motor. But I think that would always be there. And other thing is a vitamin C, like we had a nutritional discussion on nutritional deficiency. One thing is vitamin C levels that I would be thinking of, and uh, liver functions. I'd be curious to know what are the liver functions are, just to look at the secondary causes of macrocytosis.
Yeah, yeah, I was surprised there's no vitamin deficiencies, but that's what's there, except the deficiency of folate. I don't know, we don't check folate that often, and usually, as you both said, it's not low in isolation. I don't interpret liver function tests too much, but I do remember from step one that AST to ALT ratio of 2 to 1 makes me think of alcohol use. Probably there's a differential many of you could tell me, but that's my step one understanding. And alcohol use, chronic alcohol use can certainly cause a neuropathy. I wouldn't expect something subacute like this. And that can also, I think, elevate the MCV. The A1C is probably the lowest I've ever seen. So there is some lack of nutrition getting into this patient, either by the oral route or there's some malabsorption thing, though we haven't heard of any GI symptoms. I still think this is nutritional deficiency, and there's some twist in the lab testing is going to be the final move Sarah has for us. Yeah, people have mentioned infection a few times. Infectious neuropathies, really, I think it's just leprosy. Good for Sebastian for mentioning it. Sarah didn't mention any armadillos on this farm. I think that's where the host, the non-human host, um, leprosy, I think used to be the most common cause of neuropathy in the world. I think diabetes has surpassed it, and um, I've never seen my own case in the US, but they come up once in a while to specialists and specialized centers, patients who are from endemic areas. And I don't know about the skin findings being a dry scale. I think usually it's like a hypo, I don't know any dermatologic terms. It's a lighter patch, hypo, whatever patch, hypomelanotic. I don't know. Anyway, I can't think of any other tests I would do. I guess I would give folate. I'd probably give thiamine and wonder if the lab really reflects the patient's truth thiamine, or if there's some other way of testing thiamine that our lab would say, if you're really thinking about it, I would test this. Yeah, I saw people mention the hypopigmented. Thank you. I saw people mention, is it worth sending MMA? If you work in somewhat resource constrained environments as I do, if you try to send MMA with B12, the lab will always say no unless the B12 is below a certain level. And then if the B12 is below a certain level, I feel like it's not really necessary to send. Um, uh, Still gonna go with thiamine deficiency. Okay, what did you and your team figure out here, Sarah?
So as it turned out, we also had the same knee-jerk reaction as you with the AST and ALT, and went back and asked her a little bit more about her history. She had actually revealed to us that she did drink on a daily basis. And her husband revealed to us that she does not eat much and kind of grazes. But at this point, we had sent lots of labs, so I'll round those out. Her HIV and RPR were negative. She got a Borrelia antibody screen, which was negative. Her ESR and CRP were both normal. TSH was normal. Her phosphatidylethanol, which we then did send, was 654, which indicates heavy use of alcohol. And she got a LP that was only pertinent for a protein of 50, which is mildly elevated, and no oligoclonal bands. She ended up also getting a BioFire panel from CSF that was sent, and autoimmune antibody panel sent because of her kind of original picture. And those all turned up negative. She did get an MRI of her brain and C, T, and L spine, all of which had no demyelinating lesions or contrast enhancement. Um, and she ended up getting an EMG and nerve conduction study that showed length dependent, sensory greater than motor, axonal polyneuropathy. Um, so we can reveal our final diagnosis, so you all can talk about it.
Mine is unchanged. VJ, Sebastian, any changes? Yeah,
I
I don't
don't
know,
think.
but go ahead, Sebastian. Sorry.
Oh, no, I don't think so. Yeah, I think I mean, alcohol is directly neuropathic, right? But also the secondary nutritional, deficiencies, and people drinking alcohol, neuropathic too. But I think it fits. The EMG fits our suspicion, sort of. I know we were on the fence between non-length dependent, length dependent, but yeah.
Yeah. Yeah, a lot of patients with chronic alcohol use disorder develop neuropathy. I don't think of it as being this subacute, although maybe she had a background alcohol related neuropathy and then she tipped over this nutritional deficiency. Does elevated protein on the CSF mean anything to you all? We have the help of the MRI of the spine, which Sarah was smiling, probably didn't need here given the localization, but since we have it, we know that it's not spinal block from stenosis. So if the spine is open, we probably have to believe that elevated protein. Is that meaningful to you all? Yeah, you can see an elevated protein, I believe, in dry beriberi. Someone can correct me if I'm wrong, but I think you can see that. Sarah asked in the chat, do I consider 3 months subacute? Yeah, I might use these terms probably a little differently than others. When I say acute, I break acute apart into hyperacute and acute because and I consider hyperacute as truly sudden, something like a stroke or a seizure, and acute as fast but not sudden, because I think acute sort of sometimes encompasses both of those things, which um, I like to split them apart a little bit because something that's acute but not sudden, then we're more in the infectious inflammatory. And I think of subacute as sort of weeks, months, acute like days, and then weeks, months. So I would call this subacute. It's ticking along. Most neuropathies are evolving over years. It's probably hard for the patient to pinpoint when this started, especially if they're intoxicated on a daily basis, to know when exactly this started. But it sounds like if it was kind of trickling along in the background for years, might not have sought attention for it. Or maybe it has, and it just hit a tipping point of disability. Um, yeah, I think alcohol and thiamine. I don't know what to make of the normal thiamine. I don't know if we could blame this all on the low folate as the only thing. I'd certainly replete it, but I don't know if folate can cause this picture, but maybe that's what Sarah is going to teach us.
So I'm not going to teach you anything that you don't already know. But our final diagnosis for her, with all things considered, was most likely alcohol-related neuropathy with a potential nutritional component. That said, she had been taking a multivitamin on a daily basis for kind of the last few months because her outpatient doctor was feeling similar about the cause of her overall neuropathy picture. So for our management for her, we started her on high dose thiamine kind of presumptively inpatient, as well as starting her on a multivitamin to take inpatient. And then she was kind of referred for outpatient further workup and treatment. Um, so yeah.
Got it. Great. Very interesting case. Yeah, we got to talk about a lot of things about localizing weakness and numbness, about localizing this to the peripheral nervous system, um, about red flags when a neuropathy needs a further workup, nutritional neuropathies. Did you and your team find, Sarah, how to make sense of this um, tachycardia hypotension piece? Her heart was normal on echo. Is this
Yeah,
a deficiency in thiamine deficiency without heart failure, just some, autonomic dysfunction? Or how did you end up fitting that in?
yeah, I think we were trying to fit it in using, there's been like a few reports of people with alcohol associated neuropathy that get kind of autonomic symptoms as part of their overall picture. Um, with that in mind, I think it's kind of hard to place exactly where that goes on her differential, especially because she didn't have B1 deficiency. And she had been regularly taking it. So I'm not really sure. We I think did chalk it up to just the neuropathy itself.
She just had sinus tachycardia, normal echo, normal cardiac monitoring in the hospital.
Yeah. Yeah.
Yeah.
Her heart was normal throughout the entire hospitalization.
Hmm. Yeah. Wonder if just, yeah, she was having paroxysmal AFib from what's the old term, holiday heart from alcohol. Yeah, or just so dehydrated from the only sustenance going in being alcohol. It was just orthostatic. Um, just plain old orthostasis, maybe not to do with any of the neuropathy. And this was just a sensory motor
Yeah.
neuropathy plus severe dehydration and deconditioning from drinking, probably passing out, lying in bed,
Yeah.
and getting deconditioned, spending less time out of bed, continuing to drink, and just developing. A lot of patients in the hospital, right, late in their course, will be consulted by medicine because we started to work them with PT, and lo and behold, they got up and got dizzy. Like, well, when was the
Yeah.
last time they stood up? Like, I don't know, 3 weeks. Yeah, well, that'll do it. Okay, so maybe that
Yeah.
was actually you gave us many red herrings, the house in the 50s, all the animals. Um, but maybe that was also in some ways a red herring here, that that was just good old orthostatic hypotension.
Yeah.
The patient had no other dysautonomia, right? No bowel, bladder, big
No.
pupils, sweating, stuff. Sometimes you do just see
No.
outside orthostasis. But maybe that was just good
Yeah.
old fashioned. You don't even need the P there for POTS, just orthostatic tachycardia, which
Yeah.
not necessarily abnormal in the context of, sounds like a pretty severely debilitated, deconditioned patient. Yeah.
Yeah. I mean, the other thought is that it could have been withdrawal. Like,
Yes.
is she getting hypertensive and tachycardic whenever she's not drinking? And then subsequently drinking alcohol to kind of treat both maybe the feelings of neuropathy in her peripheral nerves and then also the withdrawal symptoms.
Yes, so we might have made a lumping error there, wanting before we knew more of the history to put everything together and apply Occam's razor and this patterning they teach us since the beginning of med school that when you read the step one question, everything has to fit into the diagnosis, which can be difficult. So there's Occam's razor, right, which we, I think, pretty instinctively apply and might have led us astray here. Occam's razor by, as I call it, and instead we needed to invoke Hickham's dictum. The patient can have as many diseases as they darn well pleases, right? So in this case, maybe sensory motor neuropathy and just tachycardia from withdrawal and true orthostasis from being debilitated and spending a lot of time in the supine position. Okay, I'll give the final word to Sarah. Anything else you wanted to tell us about this case? Did the patient get better with the vitamin repletion?
She continued to be seen outpatient, just was treated symptomatically, seems to be still chugging along with similar symptoms. So,
Yeah. Okay. Well, we'll
yeah.
hope with some improved nutrition and hopefully some substance abuse counseling and reduced alcohol use for some improvement in some of these symptoms. But yeah, sometimes if nerves are exposed to enough toxin, then some axons are gone and might not come back. But we'll hope for the best. Fantastic. Well, thanks for bringing this case, Sarah. Come back anytime with another one or come to discuss. We'd love to have you again. And then VJ, good to see you again. Thanks for discussing. Great discussion. And Sebastian, good to see you again. And we will look forward to seeing you the next time we do this. Have a great day. Thanks, everyone.